Hello, my name is Patel. I'm an associate professor of radiation oncology at the Winship Cancer Institute at Emory University, focusing on GU malignancies. Okay, so the question is, for which patients do we offer prostate SBRT, which is a very appropriate question, particularly now. So prostate SBRT is basically a technique of using higher doses of radiation given over a shorter course. So essentially given more radiation per day and completing the treatment in a short number of courses, short number of treatments, typically 5 treatments. And many oncologists will be very familiar with SBRT. It's a technique that's been used in many other places in the body, and now is also very commonly used in the prostate. There are some specific considerations, both patient-specific criteria and disease-specific criteria, that I think we should think about in choosing optimal candidates for SBRT. So I'll start with disease-specific criteria. In general, the best research data that we have now has largely been conducted on patients with low risk and intermediate risk prostate cancer. So these patients that have higher risk disease, that have lymph node positive disease, or even low volume metastatic disease, there's not yet a high volume of research or clinical data to support using SBRT in these cases. And I think this is something that should be done cautiously and ideally really as part of a clinical trial. That being said, I think it's important to note that using SBRT, provided that technical factors have all been met, which I'll go into in a second, for higher risk disease is something that is endorsed by the NCCN guideline. So there's a bit of controversy as to whether SBRT should be used in high-risk prostate cancer, for example. And this is something that we've all been thinking about more recently because of the COVID-19 pandemic. One of the attractive features of SBRT certainly is that it's a treatment that can be completed very quickly and limits patient exposures in the clinic. And so particularly in that setting, there have been cases where we may consider using SBRT in higher risk disease or in high risk prostate cancer in conjunction with androgen deprivation therapy, particularly to limit the risk of patients coming back and forth to the clinic. And again, using this strategy is something that is endorsed in the NCCN guideline. And for a good reason, like limiting COVID exposure, it's appropriate to consider this, when an extenuating circumstance exists. But again, the force of the data supports SBRT in low risk and intermediate risk prostate cancer. So those are the disease specific criteria. Getting more to some of the technical considerations for radiation oncologists, we want to be able to safely put the radiation in the places, of course, where the prostate cancer cells are likely to be. And with SBRT, that means we're really focusing on the prostate only, and not lymph nodes or really even the extraprostatic area. And then we want to really do our best to limit exposure to the other critical organs that are there. And of course, the 2 main ones are the bladder and the rectum, and also to some degree the urethra, because we're using higher doses per treatment. And so some of the patient-related factors are really related to making sure we can deliver an optimal treatment with respect to technically delivering the radiation without too high a risk of toxicity. So one of the first things is to make sure that the prostate itself is not too large. So very large prostate, particularly those with a large median lobe that may be protruding up and into the bladder, present a unique challenge. And these are cases that I think we want to be very careful with using SBRT. An NRG trial that's testing SBRT limits prostate size to 60 cubic centimeters. So I think that's a very reasonable number to have in mind as sort of a relative upper limit for prostate size. Additionally, I require that all of my patients have MRI. MRI, of course, gives the most detailed definition of the prostate anatomy, including in some cases identification of areas that are called dominant intraprostatic lesions, which are typically the areas of higher grade prostate cancer. And most importantly, for when it comes to SBRT, MRI is going to give us a good assessment of the extracapsular space around the prostate. If there is clear extraprostatic extension on MRI, or in some cases that's even noted on a prostate biopsy, in that case, SBRT is contraindicated, and using a more protracted form of radiation is better. So really T2 disease and not T3 disease would be an important distinction in selecting patients for SBRT. The other thing that's important for the technical delivery of the treatment is to select patients who are going to be candidates to have placement of targeting fiducial markers, as well as we strongly consider placing something called the rectal hydrogel as well. So this is a relatively quick procedure that's often done in the clinic, or sometimes requires anesthesia. Using a transperineal approach, either a radiation oncologist or urologist will place 3 to 6 targeting seeds into the prostate. These are not radioactive seeds. These are just metallic objects to help us localize the treatment. And at the same time, placement of the rectal hydrogel can be done, which essentially produces space between the backside of the prostate and the anterior rectal wall. This then allows us to design the radiation in such a way as to really limit the exposure of the anterior rectal wall and really reduce the risk of toxicity. So in our practice, we're really requiring patients have a prostate less than 60 cubic centimeters, undergo MRI, and be eligible for placement of, in our practice, 3 fiducial markers, as well as a rectal hydrogel. So with all of this in place, we then use MRI for treatment planning and carefully delineate the target. Again, really taking care to limit exposure to the bladder and the rectum. So these disease and patient-specific criteria, I think, are a guideline for selecting patients for SBRT. But again, in some extenuating circumstances, such as COVID, or difficulty with patients traveling back and forth for treatment, the NCCN guidelines does give some flexibility for selecting patients, for this type of treatment with SBRT.